Changing gears a little bit, let's talk about TAILOR. TAILOR is a phase 3 trial in second-line non-small cell patients, specifically who have wild-type EGFR, comparing erlotinib versus docetaxel. Now, I have a lot of issues with this trial. The primary endpoint of the trial was to demonstrate superiority of docetaxel to erlotinib in patients with wild-type EGFR in terms of overall survival. That was the primary endpoint, although there was no data presented at ASCO for the primary endpoint. Secondary endpoints, PFS, response rate, safety, and quality of life, were partially reported on. Here's the trial design. Patients were supposed to have tissue available to evaluate EGFR status as well as KRAS status. They allowed 0 to 2, one prior regimen that was platinum-based, and there was a balanced randomization to either docetaxel, given either every 3 weeks or weekly at the dose and schedule noted on the slide, versus erlotinib. Interestingly, this was a second-line trial. They did not allow crossover. I think many of us, whatever we use in second line, we allow patients to cross over in our practices to get the agent we might not have used. But in this trial design, that was not allowed. And, personally, I think that that's an issue from my perspective with regard to the design. The other issue is that they registered a large number of patients and excluded a large number of patients. You can see to the right there were issues with regard to having sufficient material for EGFR and KRAS status evaluation. There were issues with establishing whether or not patients had progressive disease. Many of them had non-progressive disease, so were technically not eligible. And after registering 700 patients, about 219 patients were available for the intent to treat analysis. These sorts of things always make me concerned that this may not be generalizable to the entire population of patients that we see in our practice. Likewise, here are the baseline demographics, and I'll point out just two differences. There was an imbalance in squamous histology patients in favor of docetaxel, fewer patients, 21% versus 28.4%, as well as never smokers, about 10% fewer never smokers on the erlotinib trial. And I think that in a small trial of only 100 patients, these may not be statistically different. However, they do raise a concern about minor difference in baseline demographic factors that may influence the results of this particular trial. Having said that, if I just draw your attention to the response rate at the bottom, 13.9% versus 2.2% in favor of docetaxel with a significant p-value. The interesting thing is that many of us were struck by this 4.3% of complete response rate. That's typically higher than we see. And I was equally struck with the fact that in previous phase 3 trials, when you look at response rates to erlotinib, they're typically in the range of 5 to 10%, and the stable disease rate is in the range of 30 to 40%. So these numbers were significantly different than they were from other trials. The progression-free survival data, erlotinib 2.4 months, that's actually the going rate for erlotinib, but the docetaxel arm did better at 3.4 months. And you see the hazard ratio and p-value in this analysis. Now remember, this was a secondary endpoint, as was overall response. I did not show you the toxicity data. I think that that's pretty self-evident. That these are agents that we've used for quite a long time in our practices. But I show you a table of previous trials that have treated patients largely in the second-line setting and making this comparison to chemotherapy, most of the time docetaxel, but sometimes pemetrexed, compared to an EGFR TKI, most commonly gefitinib, but sometimes erlotinib. And you see here that in these trials, the largest of which was the INTEREST trial at the top, there was virtually no difference, and the vast majority of these patients were EGFR wild type in this particular setting. So the results of this trial are very different than what we've seen from a historical perspective. And I just show you the results from the INTEREST trial. This is a slide I borrowed from Dr. West, looking at the efficacy of docetaxel and gefitinib in largely wild-type populations, although tissue isn't always available to test. We know that the vast majority of patients have wild-type. And you see to the left, looking at overall survival, there was no difference. And in fact, other than the EGFR mutants with regard to PFS, there was really no difference between these two agents from a statistical point of view. So my issues with TAILOR, The design, I mentioned the not allowing crossover, the patient selection and exclusion of the vast majority of patients, the response data out of line with previous reports, only secondary endpoints were reported, and no data on the primary endpoint. And it's my opinion at this time that the results of TAILOR should really not be used in a significant way in making decisions about second-line therapy. I think, as I showed you in the previous table, we have other databases that suggest that the choice of either a cytotoxic agent or an EGFR TKI in those patients after they progress first line is a reasonable choice either way, and I don't know that this data influences how I think about these patients in any significant manner. We have more to learn from this trial before we accept the results and let them influence how we approach patients in this particular setting.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our GRACE website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support. Thanks again.